afternoon, everyone. My name is Jason Acker. I'm a professor in lab medicine pathology and chair of the research committee with Alberta Transplant Institute. I'd like to start by just doing our land acknowledgement. We acknowledge that the University of Alberta is located on Treaty 6 territory and respect the histories, languages, and cultures of First Nations, Métis, Inuit, and First Peoples of Canada, whose presence continues to enrich our vibrant community. I'd like to thank Paladin for their support of this ATI seminar series. I'd just like to again call out that mark your calendars for the International Symposium on Systems Immunology in Transplantation. This is a exciting opportunity to come and learn more about systems immunology in transplantation, advances, challenges, and opportunities. It's co-hosted by the Alberta Transplant Institute and the U.S. National Institutes of Allergy and Infectious Disease, and it will be taking place in Edmonton. So check the ATI website for more details. So it's my pleasure to introduce our two speakers today, Dr. John Bischof and Dr. Erik Finger, who comes to us from the University of Minnesota. I know John for decades through our role within the Society for Cryobiology, where he's a fellow and past president. John obtained his Bachelor of Science in Bioengineering at the UC Berkeley in 1987, his master's from UC Berkeley as well, and the University of San Francisco, and his PhD in Mechanical Engineering from UC Berkeley in 1992. He did his postdoctoral fellowship at the same group I did mine, at the Center for Engineering and Medicine at Harvard Medical School, and then joined the faculty at the University of Minnesota in 1993. Dr. Bischof is a distinguished McKnight University professor, the Mechatronics back and endowed chair, director of the Institute for Engineering in Medicine at the University of Minnesota, and recently the director of the new NSF Engineering Center, Research Center, ATP Bio, which is really, I'm sure we'll hear more about it during John's talk. Dr. Finger is at the University of Minnesota, where he is the Eunice L. Dwan Endowed Chair for Diabetes Research and a professor of surgery. His research focuses on organ and tissue preservation. He received his Bachelor of Science in Chemical Engineering from UC Davis, his medical doctorate degree from Harvard Medical School and MIT, and his PhD from Harvard University in Biomedical and Biological Sciences. He followed that with his general surgery residency at MGH and a postdoctoral and clinical research fellowships in transplant immunology and clinical transplantation at UCSF. He's been a faculty member at the University of Minnesota for more than 15 years, and receives numerous research funding from the U.S. NIH National Science Foundation. And most recently, his achievements include the first long-term cryopreservation of organs, followed by transplantation. So we're very excited today to hear from Dr. Bischof and Dr. Finger on cryopreservation of organs for transplantation. So I will turn it over to them.
Jason is also part of a collaborative effort working with the Smithsonian around coral reef restoration. And so this kind of falls into big buckets that you can imagine. Healthcare will be what we talk about mostly today, but coral is one of the most visible ecosystems and very fragile, and we know is being threatened by climate change. And so if we can understand how to use cryobiology in the service of, let's say, coral aquaculture, when they only breed a couple of nights a whole year, and then basically doing the aquaculture to return coral that can grow into the ocean, that would be a great example or model system that we could use on other challenged ecosystems. And then food supply and sustainability ends up being another bucket. Next slide, please. So you end up with this sort of constellation of different applications that we're working in, and I won't go through all of these, but it gives you some sense for how big the idea is that we're pursuing. Next slide. So the vision is, and what we've really spent the first couple of years doing is focusing on those cell, tissue, organ, and organism systems, and really figuring out the fundamental protocols that will work to preserve those different systems. And now in this next renewal year, we want to actually really focus on creating what we're calling a cryo supply chain, or a new supply chain, cold supply chain, for these living biological systems that could be moved around the world. And the most obvious one for today's lecture, and Erik will say more about it, is what would it mean if we could actually move organs across national, state and national boundaries. Next slide. So we have this evolution, and you can just go ahead and click through it, Eric. Above the timeline, lots of really exciting work was already happening back in the early 2010s. That rodent supercooling work came out of MGH. Again, that's Mehmet Toner, Korkut Oygun. And then literally the day, if not the week that we had our blue ribbon site visit, they took the cover of Nature Biotechnology with a human living supercooling on the right-hand side there, supercooling out to 28 hours, which was 3 times the time frame that we were able to do livers before. And then there's all this other evolving technology in between, and I'll tell you a little bit about that as we go. And underneath it, a lot of road mapping. And if you haven't seen the consensus article in 2017 by Giwa et al. In Nature Biotech, that is a really excellent source to kind of see where things could go and kind of the road mapping that took place through all these different meetings and NSF sponsored roadmaps, et cetera, that you see below that timeline. Next slide, please. So to get one of these big grants, we have to be convergent, and to be convergent means that we are really bringing the physical, engineering, hard science, whatever you want to call it, on the right, together with the biological and medical sciences on the left, and we have to be addressing overarching challenges that are going to change a field. And so those challenges in the field of cryobiology are excessive ice formation, toxicity associated with the cryoprotective agents that we use. We need to avoid that, obviously. And then also avoiding thermal and mechanical stress, like when you take we don't want to crack an organ, right? So if you're dropping an ice cube in water or your drink at night, you don't want that to happen to your organ because you're going to end up cracking. So next slide. So this is who we are. We're spread out, geographically across the states, and we have 6 institutions right now. 4 of those institutions are core, and 2 are affiliate. And it's co-led, as I said, between Minnesota and MGH. Next slide. This is a really complicated slide, which I'm going to try to make easy. If you look at the green layer in the middle on the left, there are 3 what we call TAs, or thrust areas. So this is where we focus our convergent research. And so thrust 1 is biological engineering, or preparing your living biological system to go into suspended animation. And a very clear example of that is, putting or getting cryoprotective agent in and back out in a way that is acceptable to the tissue or cell. And then the second thrust is multiscale thermodynamics of water, which is really deciding at what temperature range do you want to exist. Are you going to be super cooled, partially frozen, or fully vitrified, for instance? And then the third thrust area is coming back from that suspended animation at whatever temperature range you're in. The test beds in blue are on the top. I already introduced them. And then on the right, there's an innovation ecosystem that encompasses a lot of different things, including workforce development, diversity and culture of inclusion. We've added an ethics and policy component, and Erik's going to point out there's a large symposium in the Journal of Law, Medicine, and Ethics trying to get ahead of some of these breakthrough technologies that just came out, and then stakeholder engagement in various ways. Next slide. That's fine. You can just click through those. And so we've, one back. Since getting the ERC, which was in 2020, is when we started, there's been this continued evolution of the technologies, and they've been applied across the test beds, as you can see, and we've done continued road mapping and engagement with multiple different groups, foremost among them the Society of Cryobiology, which again, Jason and I are very active in. Next slide. So we're going to transition to organs, and I'm going to hand it over to Erik here in a moment, but I just want to orient everybody. So this is actually a plot from Korkut Oygun that kind of summarizes the different breakthrough technologies that we have worked on as a center. Hypothermia is up there in the left, and that's pretty much, putting your organ on ice, which is the gold standard today still. Supercooling is what I mentioned, where they've been able to extend in liver out, to days or weeks at MGH. And now they have a new technology, which is partial freezing, that they're using in livers as well as even kidneys. And in the kidneys, they're getting out to 30 days. I don't think that's been fully published yet, but that result is one that's been vetted. And we were talking about it at our site visit renewal already. So it's a very exciting result, 30 days on a human scale kidney. And then what Erik and I want to work on is going even deeper in temperature. And as you go deeper, of course, you're shutting down the metabolism and you can go for a longer duration, is to actually vitrify. And that means ice-free cryopreservation. And as engineers, we're excited because we're manipulating temperature, pressure, and concentration to achieve this. Next slide. And so here I'm going to hand it over to Erik. And I think you heard it in his bio, but one of the things that's really exciting in our collaboration is that Erik, as a surgeon, actually has an appreciation for me as an engineer because he's got a background in engineering. And so when we have lab meetings, we really get into it on both sides of everything, both the biological and the surgical and the engineering, and it's really exciting. And so I'm pleased to hand it off to my colleague and friend, Erik.
Great, thanks, John. It's been a really rewarding 7 or 8 years, I guess, or maybe even longer than that. We started out with a little idea. Someone introduced the two of us, and we got a little seed grant from the university that turned into a small foundation award, then a R01 grant, and then another one, and on until John's recent NSF grant of multi-million-dollar. And in parallel, we've had a great success where we're transitioning what was theoretically possible to what truly might be possible for us. And our main objective is to, of course, cryopreserve organs to extend the preservation and theoretically indefinitely. When you think about doing this, you think about how cells and tissues have been cryopreserved in the past, and you think about conventional cryopreservation. Anybody who's worked in a lab might have done this, where you take cells in suspension and you cool them in 10% DMSO solution, cool them slowly in a Mr. Frosty or some insulated container down to very low temperature, and then rapidly rewarm them, and you can restore function and viability. The problem with this is that it doesn't work for organs, and the reasons are basically intrinsic to the method. During slow cooling or ice formation, what happens is ice forms outside the cells as you're cooling down in temperature, and the concentration of solutes around the cells increases because the solutes are excluded from the ice crystals. The result are that cells see an osmotic gradient, and water leaves the cells and they shrink, and the concentration of solutes inside the cells increases and inhibits ice formation inside the cells itself, inhibiting ice and freezing within, and hopefully to keep them viable. The problem is, while it works for cells in suspension, ice still forms, and it hurts the membranes outside of them. It causes injury to the macroscopic organization of the tissue, and it can cause ice formation inside the cells, interfering with function of the organelles. And there's toxicity from the cryoprotectant solutions, and it ultimately fails when we go to larger tissues and organs. So how might we overcome this? We can look to a process identified in the 1980s by Greg Fahey, sort of a forefather of this field, who showed that if you rapidly cooled rabbit kidneys, in this case, down to very low temperature in the presence of cryoprotectant agents, you can vitrify them. And you can see this on the right as the clear ice-like appearance of a vitrified kidney, which is quite clearly different than a frozen kidney on the left. And it was known in the 1980s that you could do this, but really in the 40 years since then, no one has really been able to rewarm them. And rewarming has been the critical problem since that point. One way to look at this is if you look at the temperature over time, as you're cooling. I don't know if you guys can see my pointer, but you start out in the liquid zone, above the melting point of liquid, and you drop down below the freezing point, say, -5 degrees centigrade for water, in that range. Here you enter a supercooled zone where things will eventually freeze, but not rapidly. It's energetically unfavorable. So you enter this zone where you can stay liquid, but in a metastable state, eventually forming ice. And that's where the group at MGH looks at supercooling in this -5 degree zone, and it can extend preservation by a number of days, but not more than that. You go a little bit lower in temperature, say to -20 degrees, where things will start to freeze. And if you can control where the ice forms outside of the cells in the vasculature, say, you can extend preservation even longer. And John mentioned they're able to extend preservation out to about a month or so. But we really want to go down to very low temperature, minus 120 or minus 150 degrees, somewhere in that zone where metabolism is theoretically stopped. The problem with this, as you go down in temperature, the system wants to form ice. But if you can go down really quickly from the melted zone down to this very low temperature, a separate process is occurring. The viscosity of the liquid is increasing, and eventually you get to the point when the molecules just can't rearrange to form ice crystals. We call that the glass transition temperature. If you can get down to below this glass transition temperature, which is say minus 120, minus 130 degrees centigrade, fast enough, you enter this glassy or vitrified state. The problem with it is that the rate that you need to cool water to get to that state is 1,000,000 degrees centigrade per million, or somewhere in that order, which is practically unachievable. And even more so is the problem of rewarming it, because the system is primed to form ice as you rewarm. And so you have to rewarm from this glass-like state up to above the melting point, 10 or 100-fold faster rates than the rate that you needed to cool because of its prime for forming ice. And so those are the challenges: the critical cooling rate, the rate you need to cool to form ice, and the critical warming rate, the rate that you need to warm without forming ice while you're heating up. The way we achieve it is by using cryoprotectants. Initially, the first one identified was glycerol, but since people have created cocktails of these, mixing small molecules, sugars, and polymers to form various mixtures with various properties to inhibit ice formation. The first one identified was glycerol, and this had a critical cooling rate of 85 degrees centigrade per minute, which is still probably too fast for organs, but is approachable for smaller tissues. But the warming rate for 6 molar glycerol, the critical warming rate was 32,000 degrees centigrade per minute, which is practically unachievable. This has led to many researchers trying to develop better cryoprotectants. The most efficacious one is this one called M22, also developed by Greg Fahey and colleagues. And that lowers the critical cooling rate to 0.1 degrees centigrade per minute and the critical warming rate to 0.4 degrees centigrade per minute. And now these are achievable cooling and rewarming rates. Theoretically, you could use this for vitrifying and rewarming an organ. The problem is they're very highly concentrated solutions, 9 molar, 9.3 molar, and they have toxicity associated with them. So you're balancing the toxicity of the cryoprotectant solution versus the ability to inhibit ice and that's affected by your cooling and rewarming rates. So the first system, which we showed real good success in, was pancreatic islets, and we use this for treatment of diabetes. There are a number of different sources for islets, human islets. We've tested them with a number of different species: pig, non-human primate, rodent, human islets, as well as stem cell-derived pancreatic islets or islet clusters. And we spent a fair amount of time optimizing the cryoprotectants for low toxicity and optimizing the cooling and rewarming to prevent ice formation, and ultimately to be able to store that. And what we settled on is a technology called the cryomesh. And what happens is you load the islets with the cryoprotective solution, you put them on this mesh, a porous mesh, you wick away the excess cryoprotectant so there's less thermal mass, and then you can dunk the whole thing in liquid nitrogen. And that creates very rapid cooling rates, tens or hundreds of thousands of degrees centigrade per minute, and rapid warming rates if you take them out of liquid nitrogen and dunk them in more media to rewarm them. And with that, we were able to achieve sufficient CPA concentrations to prevent ice formation under those cooling and rewarming rates and generate success. Here's just looking at the morphologically, you can see a control islet, a nice sphere of cells, and a vitrified and warm one also looks very similar, nice preserved morphology, whereas conventionally cryopreservation leads to changes in the architecture of the islets. Viability ranges depending on the cell source, and when we're doing it between 90 and 95%, and ultimately we've been able to scale it up even better than that and with better results. These islets are functional, viable, and functional. This is a marginal mass islet transplant model in mice, transplanting 250 islets under the kidney capsule in mice, and hyperglycemic mice, looking at blood sugar versus time. You can see with conventional cryopreserved islets in green, they lower slightly the blood sugar, but really don't cure diabetes, whereas if you look at the blue, the various blue things, these are either short-term cryopreservation or long-term cryopreservation up to 9 months islets. They rapidly restore normal glycemia, which is durable for as long as we followed. Very similar and actually indistinguishable from control fresh islets in that. And we've since been able to scale that up to true clinical scale processing of islets. But organs are even harder than that. In order to rewarm them, you need to do two things. One is you need to do it very quickly in order to avoid ice formation. And secondly, you need to do it very uniformly in order to avoid thermal stress and cracking. And so that's why most methods have failed in the past. The one that was first tested was convective rewarming, taking vitrified organs and dunking them in warm media. It heats from the outside. The two problems are it's slow. Convective rewarming is slow, heats from the outside, and non-uniform because you have thermal gradients by nature, and so you form cracks or ice formation. Another way to look at it, people looked at microwaves, and we all know this actually is going to fail from practical terms because if you put a frozen TV dinner in the microwave, it does rewarm, but it rewarms inhomogeneously. Part thaws before the middle, which may stay frozen. And the reason for this is microwaves have, at the wavelengths that microwave ovens work, the tissue penetration of electromagnetic field is not sufficient to really rewarm uniformly. Because of this, John and Michael Etheridge, then a grad student in his lab, developed something called nanowarming. And it's really been a sort of a clever invention where before you cool an organ to that vitrified state, you perfuse it in the vasculature with tiny iron oxide nanoparticles. Then you vitrify to that low temperature. And then when you want to rewarm it, you put the whole thing in an oscillating magnetic field. This is a solenoid coil in the middle. You can see alternating current going through that induced magnetic fields that fluctuate up and down. And those coupled to the magnetic nanoparticles within the vasculature, causing those to oscillate and generate heat. And the heating is both rapid and uniform. It heats volumetrically throughout the whole organ. So how do you do this in practical terms? This is what we do. We take an organ, we load it with a cryoprotectant solution. You have to ramp that up gradually because it's highly concentrated solution, so you slowly increase the concentration. After you get to the peak cryoprotectant solution, you add the nanoparticles, you pump those into the vasculature. You control them, you cool them rapidly in a controlled rate freezer at a sort of target cooling rate down to low temperature, and then you can store them either in liquid nitrogen, nitrogen vapor, or we use a minus 150-degree freezer for whatever period of time, and we've done up to 100 days. When you want to rewarm them, you take them out, put them in the coil, induce the magnetic fields, rapidly rewarm up above the melting temperature, and then unload the particles along with the cryoprotectant and then test them functionally. We showed this first where we could do this physically. This is looking at temperature versus time. This is the glassy zone, the temperature below, say, minus 120 degrees centigrade. The melting point, the liquid phase, in this case, is above minus 40 degrees centigrade. And these are various temperature probes throughout the kidney. You can see we are able to cool rapidly, faster than this, which is an indication of the critical cooling rate. As long as we can cool faster than this indicated line, we're successfully able to vitrify. And you can see that visually over here, where we see a vitrified, in this case, rat kidney. It's in a tube, so it looks a little hazy, but this is a vitrified kidney. Next to it is what happens if you do form ice, devitrification. You can see this hazy appearance of small little ice crystals, or cracking. You can see those obviously as linear fissures. We can verify this by CT scans, where we can see this homogeneous appearance of a vitrified kidney, which is different than the radio density that you see with ice formation and linear lucencies when you have crack formation. It's a little bit better visualization of a rat kidney, in this case vitrified and hanging by a string outside of the cryo bag we use. But there's this critical balance, of course, balancing the toxicity of the CPA versus the heating rate that we can achieve. And we struggled with this for now several years to try and find appropriate cocktails to do this. And when we first did this for kidneys, pardon all the histology, but I'm going to show you the brief version of this. And this is our original cryoprotectant, VS55. And if you look at the glomeruli, you sort of see this depositions inside the glomeruli, some injuries to the tubules. And so while we were physically able to vitrify and rewarm kidneys, the toxicity was too great in order to get them to functionally recover. We changed cryoprotectants to one called VMP, and this was the key for, at least in the rat model, we see preservation of the glomerular structure and the tubules, both in the cortex and medulla. And if we were able to vitrify and nanowarm them, the architecture is still preserved histologically. Now, this is a little bit detailed, but the short of it is this is looking at all the various steps. This is a ramp of the concentration of the cryoprotectant up as we're perfusing the organ, perfusing at a peak concentration for a period of time, cooling rapidly, in this case about 24 degrees centigrade per minute, and you can see a vitrified appearance of a rat kidney. You see a little bit of ice formation outside of the kidney in the hilar fat because that doesn't have enough CPA agent in it to prevent ice. but you can see the CT scan shows that it is indeed vitrified. We then nanowarm it, in this case around 80 degrees centigrade per minute, which is faster than critical warming rate needed to recover the organs. And then we tested them functionally. We first started doing this by normothermic perfusion as a diagnostic mode, basically pumping warm oxygenated blood substrate through the kidney and checking what happens coming out of the venous drainage and then the urine. This is looking at renal blood flow, and essentially this is a measure of vascular function or an initial survey of how the organs function. And all the color schemes are going to be the same for each of these things. Where we look at our control kidneys, these are fresh kidneys. These are in the reddish color. Cold storage, 24 hours of cold storage is in this sort of light blue color. CPA only in green, that's here, this green color, and our vitrified and nanowarm kidneys here in this darker blue. And you can see there's each of these three behave very similar. CPA only or 24-hour cold storage. Not quite as good as the fresh control kidneys, but much better than the old CPA that we did. And that holds true for most other measures that we measure. We look at urine output production, and we can see that the nanowarm kidneys had the same amount of urine production as fresh control kidneys, as well as 24-hour cold storage. Oxygen consumption rate, similar clustering, similar to 24 hours cold storage. Creatinine clearance, also similar to 24 hours cold storage or CPA only. And essentially every other measure we tested in vitro by normothermic perfusion, they behave similar to 24-hour cold storage. Not quite normal, but much better than the original one. And this prompted us to test it in vivo in a rat transplant model. And so we transplanted vitrified and nanowarmed kidneys. And what we saw, and this is, I'll draw your attention mainly to this panel here, this is a creatinine over 30 days. We saw a rise in creatinine of the vitrified and nanowarmed kidneys, a peak around 12, but then coming back over 2 to 3 weeks, it normalized and was the same as control rat kidney transplant. And by 3 weeks, the control and the vitrified and nanowarmed kidneys looked identical in essentially all behaviors. When we look at 30 days, I'm not going to share the data here, but all the renal parameters and other physiologic parameters in the blood are all normal, except for slightly lower creatinine kinase. We don't know what that significance is in slightly higher amylase. We don't know the significance of that, but those are the only two differences you got to identify in vitrified and nanowarm kidneys compared to control kidneys. But we did see that dysfunction notable with some metabolic acidosis, a mild hyperkalemia, and some hypervolemia that again resolved over 2 weeks. When we look at the kidneys histologically, again at 30 days, they looked indistinguishable from control rat kidney transplants. So we're able to show that we could cryopreserve, go through the whole process here, loading, vitrifying, unloading, and then testing the organs and see that we could have function with up to storage up to 100 days. We only tested out to 100 days, but theoretically it could go longer than that. This came with some nice recognition. This case, a cover of Science and a review article about our work. But essentially, everybody asks, the first question they ask after they hear about this is, so when are you going to be able to do human organs? Can you scale? And that's what we've been working on the last year or two to see if we can scale. And we know that in the past that the main issue has been the ability to rewarm organs fast enough. But now, since we've shown that we can rewarm homogeneously and quickly with nanowarming, which theoretically can scale to human-sized organs, and we've actually shown that it does, the problem is reverted now to a cooling problem. As you get bigger and bigger in organs, you only have a certain rate of cooling if you're doing convective cooling, and that depends on the size of the organs. Where ovaries and testes can cool quickly, 10 to 15 degrees centigrade per minute, but a big liver that weighs, 1.7 kilos thereabout may only cool at a rate of 1 or 2 degrees centigrade per minute. And so that affects the amount of cryoprotectant that you need to put into the system. And so we spent a lot of time looking at the various cryoprotectant based on an intrinsic length parameter, how large the organ essentially is. And we know that we have to increase the cryoprotectant in order to successfully vitrify and then rewarm the organs. We've now shown that we can vitrify up to now 2.5 liter volumes with different cryoprotectants. We won't go through this. The failure modes are cracking or crystallization, but we are able to vitrify large bags of cryoprotectant by changing the formulation. And we've been testing this now in human scale organs. Not going to go through the exact cryoprotectants we use, but this is an example of a frozen kidney, very similar to what we saw before in Fahey's initial study showing a frozen rat kidney. But if we add a different cryoprotectant agent, we're able to vitrify them and see that we're successfully, you can see the appearance of a vitrified kidney with glass-like liquid around, it's actually not liquid, I guess it is liquid, but it's ice-free vitrified substance here. Again, a little bit of hylar fat that has ice in it, but we're able to vitrify throughout the kidney. Also able to scale up even further. This is pig livers, and we're able to at least do juvenile pig livers up to, say, a kilogram in size. But it really becomes this balance of the toxicity of the CPA, and right now that's what we're working on, is to trying to overcome the toxicity so that we know they can vitrify, but how functional are these organs, and that's what we're currently testing now. Also, the rewarming. Our initial coils for doing this start out as a small coil with something that's sort of the size of a toaster oven. Our medium-sized one that we use for rat and rabbit organs is, say, the size of half of a room or a large broom closet, say, and that can go up to about 80 milliliters. But John and team had developed a new system that we've since put in place and now testing that can go up to 2.5 liters in volume, which is suitable for human kidneys and human hearts. Not quite for human livers, but hopefully we'll go there next. And we're working on characterizing that, and hopefully we'll have more data for that shortly. So things have progressed pretty rapidly, starting out with small rodent livers 10 years ago, moving up to rabbit kidneys, and now human-sized organs. And the pace is really increasing rapidly. The way that we're able to move through each of the organs in the human-sized system is really promising for future developments. But the question becomes, what does this all mean? Why extend preservation time? As we know, preservation limits are typically, say, 4 hours for a heart, and long up to 24, 36 hours for kidneys, but that generally leads to regional or even local sharing and limits our ability to broadly use organs. If we can cryopreserve them, we now extend the ability to share organs, not only across the country, but potentially even globally. And this gives you time for tolerance induction protocols, better matching of donor and recipient, global sharing, and elective surgeries, doing cases in the middle of the day rather than the middle of the night, which is quite an advantage for people like me. And it really will change the sort of organ allocation system, at least here in the United States. We have, identify one donor, and we decide one at a time whether we're going to take that for one particular recipient. We do whatever transport we need to and put it into that recipient. But really, you can change the system where you take multiple donors, take the organs out, cryopreserve them, put them in a bank of some sort, and pick the best one for the best patient at the best time. Now, of course, this is a challenging ethically, legally, and societally. And we have a big component led by Tim Pruitt and Susan Wolf at the University of Minnesota under the guidance of John Bischof, of course, which just released this paper in the American Journal of Transplantation, sort of a beginnings of what might be considered for what are the ethical and societal implications if we are able to extend preservation, who gets what organ, and how do you regulate that? And this has also now led to a full symposia, if you will, led by Susan Wolf, published in the Journal of Law, Medicine, and Ethics, looking at various different components of the cryopreservation or extended preservation in general, and how those might be viewed, with a number of different ethics, bioethics experts contributing to this. And it's really been a quite exciting thing, and sort of a hallmark of our group to sort of have them working with us in parallel to sort of say, what does this mean in the long run? So again, reiterating what John had said, we like to thank the people that supply organs and support our funding. We have a lot of different funders and a lot of different people contributing. And I'm only going to show a partial list of the lab members and collaborators that work most closely with us. But certainly a lot of people contributed to the work that you saw. And finally, I'll leave it back with John's initial sort of thing. ATP Bio seeks to cryopreserve lots of different structures, from cells to whole organisms, for a lot of different important biological purposes. And maybe you can finish off and see if there's any things that he wants to add to that.
No, I think you did a great job. Thanks, Eric. Happy to answer any questions.
Thanks, John. Thanks, Eric, for a wonderful summary of the exciting work that's being done in Minnesota. So we're open up for questions. You can come off mute, turn on your videos, raise your hand using the raise hand function, and would love to hear questions. I could always start, Eric. So you highlighted obviously a lot of the exciting work that's being done with liver, but what about other organ and earlier work with islet cells? But what about other organ systems? Where are we with looking at the more complicated hearts?
Yeah, we actually started with hearts, and what we found, as you might expect, is each organ behaves a little bit differently. Some it's just because of the cryoprotectant. Some are more sensitive to the cryoprotectants. What we found is that the best cryoprotectant for liver is different than the one for kidney, and the heart is even more sensitive to damage. probably in addition just to cryoprotectant toxicity, it's just the amount of time that it takes to load and unload them, is several hours at our curtain process. And, that ability to preserve under standard conditions of heart is only 4 to 6 hours. And so we're sort of running up to that just with our loading and unloading conditions. And so we are working through those where some tissues, and particularly tissues, are easier in some ways because they don't have as much complex architecture, but then they don't have vasculature to adequately get good CPA diffusion into the tissues itself. But we're working on each of the different structures. It gets even more confusing when you start talking about other organisms like insects or things like that, or other biologicals where there's a shell or an encasement where you really have difficulty getting the cryoprotectant in through a protective layer. And people within ATP Bio are certainly working on those challenges as well.
Now, you mentioned obviously the opportunity that or cryopreservation would have in terms of organ matching, but what else? I guess it's going to open up a potential whole other realm around immune tolerance induction. It's going to really or open up opportunities for how we actually treat recipients in a variety of different ways. I'm not sure if you want to comment on any of those opportunities.
Yeah, so some are just practical things, better matching of donor and recipient. There's a lot of work these days with eplet matching. For those of you at the, might have heard about, you guys have some people up there that are experts in this as well. Just better matching of organs in general, but that's going to give you a few % difference in 10-year graft survival, if you will. But what if you really want to improve things with, say, tolerance protocols? The current tolerance protocols are being tested. The combination of hematopoietic stem cells and kidney transplants, the MGH Stanford and Northwestern protocols. Those typically take a few days of conditioning of the recipient, plus up to a few weeks to prepare the hematopoietic stem cells. And so it really would help to prepare patients for those type of protocols, or tolerogenic cell infusion, Tregs, or apoptotic donor leukocytes. Those often take a period of a week or so to, after the infusion of cells for you to, put in the organ. And so if you could cryopreserve, you better be able to prepare the patient through whatever tolerance protocol you choose to try.
Yeah, and maybe just since there aren't a lot of questions, I could just offer a comment. We had Anthony Atala, who I think many people know well in the regenerative medicine field, and he's doing a lot of autologous tissue regenerative medicine work at the Wake Forest Institute for Regenerative Medicine. And he came and gave a real wonderful talk at Minnesota just, I don't know, about a month or so ago. And in the past, he actually sits on our scientific advisory board for ATP Bio. And so he's been aware of what we do. But when we first started talking to him, he was like, well, I don't see any reason for cryopreservation with what we're doing. But we walked him around and talked to him, and Erik talked to him as well. And he walked away with a comment saying, maybe there is an opportunity here, even for the autologous, because if anything goes wrong, and this kind of goes to this, immune tolerance is kind of like one branch of that, but like preparing the patient, right? If there's any delay, or the patient has a fever or whatever, somebody trips on the way, taking the thing to the hospital, then you need a backup plan, and that's where cryopreservation might come in. So, and then we didn't even get into xeno at all, but I'm sure, Erik can tell you lots of ideas around that. And I think there too, there's going to be a need for cryopreservation, just in terms of the supply chain aspect.
Yeah, I was just going to ask that question. You showed data or showed examples of both human and porcine organs, but with obviously the success of the alpha-gal and what's going on in xenotransplant, do we expect that there's going to be any differences in the protocols that we might apply to a porcine organ versus a human organ, based on what you guys are seeing?
We don't think so now, because the size is really mostly at this point a physical constraint. It's possible we could find some biological toxicity that's different, but we think right now it's mainly a size-based issue that we're dealing with, the physics of it rather than the biology of it on an organ to organ level. But even with the xeno, you know, they raise the pigs on farms, and they take them from one, you know, fancy OR, you know, veterinary OR somewhere, and then they bring them to Mass General or wherever they're doing the transplants. At least the last ones they did. It still takes several hours to get them there, and so there's still a need, even when you have an on-demand supply of you know, of a non-human donor to extend the preservation.
Yeah, one other aspect of that that occurs to me is that when you're doing the xeno, you're growing these pigs, you know, they're all the same age, they're all fed the same diet, you know, and everything. So the ability to actually work out the protocol and have it more robust is probably higher, I guess. You know, you don't want to say that, but it's probably true. Because people are going to come in, you know, from old to young with different size and different conditioned organs. And that also speaks to another opportunity that we've been discussing with Seb, who you know well, Seb Giwa. Seb's really excited about the opportunity of, you know, so Erik talked about our scale-up problems, but Seb actually sees an opportunity even at the rat scale, which is, okay, well, we have pediatric organs, right? And we have pediatric donors. It's not a wonderful thing to live through, but they're there. And then, of course, you have pediatric patients that need those organs, but they're probably few and far between in comparison to the adult population. And so there again is a really strong argument to be made for the use of cryopreservation, because there is nothing else to offer those pediatric patients, right? You're not going to, even if you had an adult organ available, you're not going to be able to get it into that. And Erik, you can clean up my response on that, but it's just not going to work, right?
At least for heart and lung and liver. For kidneys, we do you know, adult size ones in the pediatric, but one of the challenges is because there's fewer pediatric patients waiting for organs in general and fewer pediatric donors, and they could be geographically separated. And so an organ that might be available at one time and place may not match up with the need for a recipient at a different time and place. And so if you have them in a bank, you would be better able to utilize them once they get discarded now.
I think you just muted yourself successfully, Jason. I've been trying to do that for years.
Thanks, John. We've got Lori. I think Lori probably wants to comment on this, and then we'll jump to Sophie. So Lori, do you want to jump in?
Hi, yeah, this is really exciting work. And you bring up, I was sending emails furiously, but I may as well just talk to you that, I mean, some of our infant heart transplant patients are newborns, you know, they're tiny, and obviously their donors need to be tiny. And it's not that we're looking for tragedies to happen, but the dispersal, the geography around all of North America is, you know, we're already pushing the limits when we fly an organ from Quebec to Edmonton, for example, and it's really important. So I see huge possibilities for this technology, especially in pediatrics, as you've said. Thank you for presenting this work. It's really exciting.
Thanks, Lori.
Yeah, thanks.
I see.
We'll go to Sophie.
Yeah, Sophie.
Hi, thank you very much, Dr. Finger and Dr. Bischof, like a super exciting work. Great to see like you're working on scaling up on the vitrification and potentially towards organ banking. You know, like we've been working on bringing new cryoprotectants on the peptoid side. Recently demonstrated the world first kidney journeys we can use very simplified system with our solution maintain -5C no frozen and the transport through the continents. So I see a huge potential so we can work synergetically in the future. That is my question, like wondering like for scaling up to the human size organs towards the clinical translations, do you envision your system for cooling and the rewarming will be decentralized into different transplant centers, or will be centralized the center, like you will need some like support from logistic perspective?
Yeah, I mean, I can start, but I think Erik should obviously weigh in on this. But I think the cooling part of it is something that a lot of places can do. And I think the warming part of it, not so many places can do. So it's probably going to be, you know, getting the perfusion technology and the cooling technology out to transplant centers all over that want to participate. And then the rewarming piece will probably be, you know, just in a few key centers. Erik, do you want to add to that?
Yeah, you could really see you know, a synergistic union between, say, the work that you and your collaborators have done with high sub-zero preservation, or normothermic or subnormothermic or whatever version of perfusion you like to think about. You know, or maybe the last mile kind of argument. You know, we may be able to be the bank, or there may be some regional banks, if you will, but how do you get them to the bank and from the bank to the transplant center? The equipment for rewarming, the current version, is big with a lot of voltage and a lot of cost. So it is impractical for every center to have one. Although we have colleagues that are working on trying to make, you know, sort of cheaper and smaller versions, if you will, but likely it's going to be some sort of combination of long-term storage and better short-term things to get to and from those areas of long-term storage.
Yeah, this is super exciting. Like, imagine we can bank the organs, like we can make the off-the-shelf potential best matching, and we're ready to support like in any moment.
Thanks, Sophie. Was that the work with was Gerald, right?
Yes, yes, we're really grateful, like to be able to demonstrate organ now can use a very simple system to cross a continent, or
Yeah.
simply applying what you have worked on, improving cryopreservation and then reduce metabolic rates. And I think this will be a bright future.
Yeah, very exciting. Thanks.
Thank you.
All right.
So
So
one of the things that comes up has come up to me when people talk about it, and I'd be curious to hear Erik or anyone else comment. But like, okay, let's say we have a bank of kidneys or something, right? Let's just start with kidneys because that we're getting the best results there. What does that do to the existing organ waiting list, right? I think that's a really interesting question, and I think, you know, Tim Pruitt, Erik mentioned, who's our colleague, who's really thinking about this also from the ethical and regulatory side. You know, he's saying that we need to show equivalency, right? Substantial equivalency, and I guess the FDA, that's kind of FDA speak too. And of course, you know, a kidney that goes through a cryopreservation process won't be the same kidney as the, you know, if that kidney had been taken directly out of a donor and put into a recipient. So in my mind, it seems to me that there's probably going to be a separate, you know, organ list, if you will, if you have banked organs, and people will have to elect to move from one list to the next. And I don't know if Erik's thought about this, but I'm poking at him now, because if I was on that list, you hear about people dying on the organ list all the time, and sometimes it's quite tragic, and they're young. And I mean, it's always tragic, but if it's a young person who's waiting for a kidney, for instance, and if they don't get an organ, they're going to die. And then you have the opportunity to take a cryopreserved organ, even though it's maybe not substantially equivalent. Should they be allowed to do it? I don't know, Erik, do you want to? I know
there's already a lot of basis for this discussion in other areas. You know, older donors, younger donors, who gets what organ. You know, what's a benefit to the individual, what's a benefit to society in terms of getting more people out dialysis, what's the benefit to the transplant centers, and there's a lot of different things for people to consider when deciding how those go. Our current, you know, the current rat, at least transplants, look like delayed graft function kidneys, and that there's some early dysfunction that resolves completely, at least in rats. And so, you know, it sort of seems like they could fit within the current system, but maybe that's not going to be effective for, you know, a 75-year-old donor's kidney. You know, maybe add a little bit of of age to begin with, and there may be too much injury in the end. But it's going to really, it would totally change the allocation policy practice to figure out what's the best use of them.
Yeah, so it sounds like a lot of the same conversations around DCD donors and how we look at allocation. We're adding now another criteria, the cryopreserved organ, and how does that fit into the the overall management of recipients. So very exciting. So thank you both for taking time today to join us virtually and cover this very exciting topic. Obviously, one of interest to me.